currently how we monitor patients on the general care floor is in snapshots of time, meaning a nurse or a provider will go into a patient's room every 4 to 6 hours and do a set of vital signs and check in on a patient. That, based on what myself and other investigators have uncovered, is very inadequate. And the reason I say that is because we have shown in our prior investigations that low oxygen saturation or hypoxemia, hypotension or low blood pressure, and even hypoventilation is common and profound and persistent and goes unnoticed for long periods of time when this sort of snapshots of monitoring policy is implemented by hospital systems. And that, for me, is the biggest gap that exists right now. If we are able to implement continuous monitoring, we are going to be able to see these changes in vital signs. We're going to be able to correct for these changes in vital signs. We're going to be proactive in our interventions before patient harm actually happens. And that's more so because we know that patient harm or these overhead code blue calls that you and I hear when we get into hospitals don't just happen all of a sudden. This is a gradual change in vital signs that occurs over 4 to 6 to 8 hours. And if we had continuous monitoring, we could see this pattern change evolve in front of our eyes and go in and correct it, intervene early, and possibly and likely save several lives. The interesting piece is that intraoperative mortality is next to negligible. We are now operating on patients who are older, who are sicker, and who have more complex comorbidities as they come into a surgical operation in an operating room. Yet, patients do not do well in the first 30 days after non-cardiac surgery. In fact, if the 30 days after non-cardiac surgery was taken as a disease entity in and of itself, it would be the third most common cause of mortality in the United States of America, only after diseases of the heart and malignant neoplasms. That tells you that patients do well inside the operating room, where surgeons are operating on them and anesthesiologists are taking care of them. However, when they leave the four walls of the operating room and come to the post-anesthesia care unit, the perioperative environment, and the general care floor, that is where things start going wrong. If we look at why patients don't do well post-operatively, there's 3 or 4 important reasons. There's infection, there's bleeding, and then there's myocardial injury after non-cardiac surgery. We cannot control a lot of post-operative bleeding. Some patients, by virtue of their operation and their medical conditions, are likely to bleed. We cannot control a lot of infections post-operatively. Again, by virtue of their surgical conditions, some patients are likely to have infections. What we can control is myocardial injury after non-cardiac surgery. Data has shown that this entity, also called MINS, is very strongly associated with post-operative and intraoperative hypotension. During surgery, we have all eyes on the patient. We have continuous monitoring. We can see hypotension as it happens and correct for it. Once the same patient comes out of surgery, and is in the PACU and then goes to the general care floor, then we switch to intermittent monitoring again. With intermittent monitoring, we miss a lot of post-operative hypotension. Myocardial injury is dangerous. Not only is it associated with hypotension, it is silent, which means patients do not experience any chest pain. All that really happens is an increase in something called serum troponins, and it is not troponitis, it is myocardial injury. This myocardial injury is associated with significant mortality in the 30 days and in a year after non-cardiac surgery. So all put together, continuous beat-to-beat hemodynamic monitoring is the answer. If we have to really see how our patients' hemodynamics are behaving in the PACU and on the general care floor, and if we're going to correct for one of the biggest killers in the post-operative period, which is myocardial injury after non-cardiac surgery. What really excites me is the fact that there's a huge opportunity to intervene and save patient lives. Patient lives that we are otherwise losing after we work so hard on them in the operating room and the ICU. The other part that really excites me is that monitoring technology is getting smaller and more portable. The only way we can achieve better patient outcomes is by making technology portable and acceptable to patients as well. Understand that patients are the ultimate consumers of the product because they are the ones who are going to wear this technology and experience the benefits of it. They have to adopt and accept this technology and embrace this technology. And finally, what really excites me is that all of these portable technologies now very seamlessly flow into the electronic medical record, and this data can be captured and captured securely and in a granular form. As I wear my research hat and my big data analytics hat, I will tell you that I look for this data, I yearn for this data, I want this data, because ultimately what's on the horizon is the ability to predict and prevent harm. So we should have some sort of smart system that can tell me and can tell my colleagues that this patient is likely to be hypotensive 2 hours from now, 6 hours from now, 10 hours from now, or for that matter, have another respiratory or cardiac complication. And that's where the value of this portable, continuous beat-to-beat hemodynamic technology is.